Welcome to MAP, the bi-weekly market access podcast provided by Mars Market Access and Pricing Strategy, which is your healthcare consultancy in the German-speaking markets. Mars makes it as easy as possible for you to get your pharmaceutical, medtech, or digital health product to the market and, of course, get the price it deserves. My name is Stefan Walzer. I'm the founder of Mars and a health economist by training and working in the fields of market access, reimbursement, pricing, and health economics already since 2004. And now let's learn about the market access and reimbursement systems around the globe. Today we're talking about Italy. We love Italy for its dolce vita, the tasteful wine and amazing food. What is less known is that the Italian healthcare system has some of the most prominent research centers around the world and a challenging reimbursement system as well, which is in some parts also similar to the German system, at least from my perspective. Let me now first introduce the Italian reimbursement system before we will speak to two well-recognized experts from Italy on specific aspects. So the market access processes in Europe obviously are diverse. I mean, we have learned how the German AMNOG is working, but what about the other countries? So as a clear and good example of a long-lasting, already very experienced health technology assessment process, we can take as well Italy. Why Italy? Because I think we could maybe discuss as well later on with some of the Italian experts if maybe Italy is a kind of light version or maybe even a kind of more acceptable version of the German AMNOG. But before we come to that discussion, let us quickly rephrase and explain how the Italian system basically works. So in a way, the very first step after the approval of the drug in Europe by the EMA, a company can submit their dossier, their health technology assessment dossier, to the so-called AIFA. AIFA is the ultimate decision maker in Italy, and I think we can also learn in a short time frame a bit more about their specifics. So this dossier will then be, first of all, evaluated by the so-called CTS, which is the Technical Scientific Commission. And what they do is quite similar, at least from my perspective, to the German GBA. They are evaluating the clinical benefit. And the clinical benefit here is even a bit more clearly defined in the method section for Italy. What they're looking for is, as well, besides the kind of added benefit, on the kind of innovativeness of the product. And how is this defined? It is basically defined in the way that the assessors are looking for an unmet therapeutic need in a given disease area for that product. It is the therapeutic added value, very similar what we can as well remember from the German AMNOG process in terms of added benefit. And also here, very similar, it is obviously compared against the available alternatives in the market. So this is as well an important differentiation. Potentially, let's discuss later on as well, it is already the plural. It is more than one alternative, which is currently the kind of phase how the GBA is assessing it. And then thirdly, in Italy, they're also looking on the quality of evidence. And here the AIFA is explicitly using the grade method. That's also, again, from my perspective, quite similar in its way. So after the CTS has basically then come up with the innovation scoring, because that's important, they are basically then giving that further back to the AIFA, where then the pricing evaluation is kicking in. Again, from my perspective, very similar in terms of the AMNOG process, as we first have the GBA assessment. After that, it is followed by the price negotiation with the head association of the statutory health insurance funds. So important again here is when you think about the innovation status. The innovation status can have two different results here. Firstly, it can have a scoring of full innovation, or it could also have the results of a partly innovation kind of status. Why is that maybe important? I mean, if there is a full innovation status, it has access to economic incentives for 36 months. That's an important consideration, especially if you have really an innovative and costly therapeutic in your hand. And secondly, there might as well be benefits of resources deriving from budget savings. That's maybe also a question I would personally as well have, for example, to our Italian experts, how this would really look like. And also, and especially, we're as well touching base on that a bit later, how this would also come into effect when we think about the differentiated market in Italy, as we have all of the different regions and even on a local basis, the kind of differentiation further, which is again a kind of big difference to many of the other healthcare systems in Europe. Independent of that, I mean, once the whole kind of, let's call it added benefit or benefit assessment by the CTS, there is then the price negotiation, which is also happening. And I think also keeping in mind quite clearly a key consideration in that price negotiation is the benefit assessment by the CTS, but also the kind of cost-benefit ratio, which is also being assessed by the CTS in a first stage, right? And further criteria would be the place and therapy of the new product. Why is that important? Obviously, the later you are in the line of the therapy, the fewer patients there might be. So that might be maybe a consideration, especially where there might be potential either safety questions and or obviously a budget impact question for that. Related to that, obviously as well, the treatment cost per day ratio is being considered and further aspects as well. So how could then a kind of entry really look like? I mean, how could you really come up with a price arrangement, right? A lot of times it is quite clear, as in many other countries, there are different kind of discounts given. But it's also important keeping in mind the AIFA in Italy was one of the very first institutions from a payer's perspective already agreeing and negotiating managed entry agreements. That was already done many years ago, already roughly 15, 18 years ago, and they have had as well installed just for that the so-called AIFA registry. That's maybe as well an important consideration when keeping in mind when and how and also at which price you potentially want to launch a product across Europe, but here specifically in Italy. After the CPR evaluation is then finalized, so also the pricing, the results of the negotiations are then submitted to the AIFA's board of directors for a final evaluation. So is this then already everything done on a national level for Italy? Yes, on a national level, of course. But I think then we all know that there's a quite big regionalization in Italy, and hence the kind of story could even go further. And I think that might be maybe as well the very first question to our experts. How does that really look like, besides the point that the whole kind of AIFA process could be maybe seen as a kind of light version of the AMNOG, potentially? Not exactly sure, because the process, as we have just heard, is very similar in a way to the German AMNOG process. And the other, the second, I think to me even more important question, how do now these drugs really come to the patients? I mean, there might be even further health technology assessment or other kind of market access entry barriers on a regional or even on a local level. And I think this is sometimes not that clear, but just out of my experience, it can even last years until a product can even reach some of the regions or some of the hospitals, even that it was approved and agreed on by the AIFA. So let us listen what the experts say to that. The introduction is set. Now let us deep dive, and we start with Entela Xoxi. Entela works in the Italian healthcare system since 2007 and has especially also worked for the Italian reimbursement agency, AIFA, for nearly 10 years.
We know that Italy is one of the European countries where the drugs prices are regulated through negotiations. The Italian Medicines Agency is the national authority responsible for regulatory pricing, reimbursement, and health technology assessment related to pharmaceuticals, including governance of pharmaceutical expenditure. In Italy, we have two advisory committees, technical, scientific, and pricing and reimbursement. But the particularity of the Italian market access is related to 5 characteristics. And there we can find now a kind of AMNOG light in this sense, specifically on the innovation scheme. First, the price and reimbursement for new medicines are simultaneously negotiated by the Italian Medicines Agency and the relevant pharmaceutical company. Secondly, Italy is among those countries which rely on a multi-criteria approach. And this is something different from the German aspects. Third, over the last decade, IFA has extensively relied on managed entry agreements. We know which is the definitions of managed entry agreements are arrangement between manufacturers and payers that enable access to health technology subject to certain conditions. And these agreements manage that kind of uncertainty, clinical and economic, with impact on drugs. So Italy, as well in other healthcare systems, managed entry agreements are negotiated with price discounts are confidential. And the fourth characteristics of the Italian aspect is registries. Registries at national level, important operational part of the pricing and reimbursement negotiations between IFA and pharmaceutical company, and are a key element of the contract between the two parties. And the last particularity is the early access program. For drugs, we have this early access programs, including compassionate use, which is covered by industry, but also we have some off-label use reimbursed by National Health Service. And this off-label use is allowed by the IFA in given circumstances with different regulations, but the most important is the 648 law, that provides for data collections before the drug enter into the negotiation process. And specifically for that 648, we will discuss a little bit more later on, because the new Italian market access process or the new pricing and reimbursement criteria are changing the typology of the negotiations. So looking at these 5 characteristics, and with the new resolution or new deliberations of 2020, IFA has adopted the consolidated versions of the new guidelines on the preparations of the dossier supporting the pricing and reimbursement applications for of medicinal products, pursuant to the ministerial decree of last year on the criteria and procedures according to which the Italian Medicines Agency negotiate prices of medicine reimbursed by the National Health Service.
So, is it true that the Italian process could be called an AMNOG light? And what could we in Germany potentially learn from it?
The question could be answered by finding the point in common between the German and Italian assessment. And then I have some advices what Italy can probably teach to the German perspective. But first, I saw different factors or characteristics in common with the German, specifically with this new guidelines. 5 potential influencing factors are assumed most relevant for AMNOG, for the Act on the Reform of the Market for Medicinal Product in Germany. So you have rating as the results of benefit assessment, the indication class, the orphan drug status also reflect the size of the target populations. You have also the appropriate comparator therapies depending on number and annual cost, and also the health-related quality of life when incorporated into the assessment. So a ruling on additional benefit, 6 categories from major to less benefit for a specific compound by the GBA, so a specific appraisal, is based on the overall assessment of the evidence present in the dossier for effects on mortality, morbidity, and health-related quality of life. So the acknowledgement of a patient's relevant medical benefit by the GBA is crucial. According to the new IFA guidelines, the new criteria on pricing and reimbursement, and in relation to the clinical condition to which a medicinal product is addressed, it will be need to specify also the course, severity, the disease in terms of mortality, disability, years of life lost to the disability, and premature deaths, so DALYs, impact on the quality of life of patients, and more generally, every aspect characterizing the impact on patients and on society. This is very challenging. It's a new mode of the descriptions of the disease, and this new aspects on quality of life. It's very new for the Italian, so it's similar. I try similarities with the additional benefit evaluated by GBA, and this it's more specifications in order to define better the add therapeutic benefit. And the other component is the quality of evidence and also the comparative therapy. I mentioned before something about the comparators in the previous questions, but the number and characteristic of the studies provided the certainty of results, and the observed effects determine the level of quality of evidence. And very similar to IFA approach related to the grade methodology on robustness of clinical evidence. And also with regard to clinical studies supporting reimbursement, IFA will ask, as soon as the new decree become effective, whether the clinical trials are conducted with the aim of highlighting add value with superiority studies, or overlap, for example, with equivalence or non-inferiority studies versus the therapeutic alternatives. Where possible, in this case, IFA will request data on impact on quality of life through internationally validated scales. So this last details completely change the Italian evaluation scenarios, but are very similar also with what the AMNOG benefit assessment. What, for example, Italy can probably teach is that this multi-criteria process in terms of the evaluations or pricing or reimbursement negotiations, and also another characteristic could be the applications of managed tenure agreement, specifically, for example, the performance-based risk-sharing agreement or outcome-based. The example could be the incoming advanced therapy medicinal product, and this could be a very, very interesting area to be applied. And the last point that I can suggest could be the utilizations of post-marketing registries or real-world data as part of the negotiations strategy, especially for the advanced therapy and also for the implementations of performance-based risk-sharing agreement.
Stefano Capri is Professor of Health Economics at the University of Catania in Italy, and is also working as a member of the HTA institution for the regional payer in Lombardy.
Well, I can start very briefly maybe to describe the main points of our system. Is a negotiation-based system. The process is quite simple. The company has to ask for the negotiation. So there is a format, there is a price reimbursement dossier to follow with a number of chapters. I don't know if it's anything to go through, but they are the normal information that are supposed to give to any system. So which is the drug, which are the comparators, which is obviously the price that the company is asking for, which are the evidence coming from EMA approval. Obviously, we are not talking about other studies. There is specific sections about which are the investments in terms of production sites in Italy, eventually, if the company has some production sites, which are the prices. Which are the prices already approved in other countries. There is a list of countries covering, I would say, all European countries, which are considered the reference countries. obviously, in practice, some countries is more relevant than the others. Obviously, I don't know, the price in Portugal could be maybe interesting, but is not influencing like the price in Germany, which is quite obvious in terms of relevance of the country, of the market particularly. We are talking about the market. And we are talking about systems that are closer to the Italian system. Then we have one section related to the economic aspects. One is the budget impact. Just to say that if you like, maybe I can comment further some new insights in the guidelines that IFA is expected to issue in the next future, but just briefly saying, so there is the budget impact, which is absolutely mandatory since many years. So briefly, the company has to provide a 3 years forecast of the market share of the product, showing obviously which will be the situation in the next 3 years without the product that is negotiating, and which will be the situation with the inclusion of the product. Obviously, the company has to provide subjectively which will be the expected market share. Just to say that the main variable that IFA is taking into account is the pharmaceutical impact, even if obviously a good budget impact is providing the impact on hospitalizations, on visits, on diagnostics, on the other healthcare resources. There is also, is already a practice since many, many years, the possibility to provide a cost-effectiveness model, which is normally, according to my experience, a nice model adapted, tailored to the Italian situation, as it happens, I think, in quite a few countries, with the Italian costs, with some maybe Italian medical practice, etc. Just to say that IFA, if it's paying a lot of attention to the budget impact, is not paying attention to the cost-effectiveness analysis. We are still not a country, a cost-effectiveness country. We are a budget impact, negotiation, balance, interest country.
These are very helpful points to get a better understanding. But as I mentioned in my introduction, there's also one very important aspect.
As you said correctly, we have the national system, so it is a national health service, but each region has a very strong responsibility to adapt, to provide the real health care to the citizens. So in terms of price or reimbursement is national. So the price is fixed by IFA. The reimbursement level, which means that maybe it's a hospital drug or is not an hospital drug, with other maybe differences, is national based. But we have the regions. I would say that when we are talking about no hospital drugs, means drugs that are in the outpatient setting, so are not belonging to the hospital or specialists based in hospital decisions. The regions normally they don't do nothing. It is something already approved. Each region has the normal monitoring activities for GPs, which is quite efficient, so it's possible to know every month which is the number of prescriptions of a GP. So at that point, it's quite easy to find the outliers, the overprescribers, and start a kind of discussion why are prescribing so many drugs of this kind, or etc. But when we are talking about hospital drugs, the situation is different. Also because the cost of these drugs is very impacting, particularly in the recent years. So we may have roughly two kinds of regions. One group of regions are regions with a regional hospital formulary, which is a very powerful tool, because when there is a new product, in most of the case, there is another negotiation in some way between the company and the regional health authority. The regions wants normally to see again the same dossier that has been provided to IFA with the regional data. For instance, the budget impact must be consistent with the regional numbers, the epidemiology with the regional numbers. Just to say that at this level is more relevant to show also the hospital costs, because the region is responsible for any kind of healthcare resources. On the opposite, IFA, in principle, is supposed to be responsible only for pharmaceutical expenditure. Another aspect of the regional system is that very frequently when we have an hospital product, in almost every case, we have the liberty of each region to decide where, in which centers, in which hospitals is allowed the prescription of the product. In many products, this was a very powerful tool for a region, because it's obvious if in one region the regional health authority decide that this, PCSK9 product is available only in 5 centers, you may understand that the access is restricted. So that's absolutely a very strong, powerful tool, and it is just a regional responsibility that's absolutely clear.
And last but not least, we should also be aware of the discounts that are common in Italy.
When we have a new product, we can imagine something around 30% of discount. So the net price is very close to the 30% less than the ex-factory price. It depends on the product.
So as a summary, is it now really the Amnok Light in Italy which is being applied? I think after having heard the various experts in Italy, and I know there are also other kind of mindsets and maybe also thoughts about that, I would maybe still say that there might be some aspects which are close to an Amnok Light, but at the end of the day, very clearly, as in Europe, across the different countries, there's still very much some kind of uniqueness as well included in the system. I think the price negotiation is probably as hard as in Germany, but it is also organized very differently. The submission process is, I think, at least from a dossier perspective, a bit more pragmatic. That is what we heard, I think. But still, it needs a lot of information and a lot of back and forth as well, which is also a core difference to the Amnok system. And finally, also quite clear, even when you have maybe received a positive decision by the IFA in Italy, there might, depend on the product, still be the fights on a regional and a local level, which is also a bit of a difference, I think, to Germany. That was an episode of MAP, the Market Access podcast provided by Mars Market Access and Pricing Strategy, which is your healthcare consultancy in the German-speaking markets. MAP is available every second week with a new episode, so watch out. And in case you might have questions, contact me directly and or visit our website on www.marketaccess-pricingstrategy.de.